In this video, we're going to talk about how to dose aminoglycosides. We are going to start with some basics as a refresher, and then we're going to get into the meat of the video, which is how to dose these drugs. Okay, so aminoglycosides are a class of antibiotic. So let's try to name some of the antibiotics in that class. Can you think of any? Some of the more commonly used ones are going to be gentamicin and tobramycin. And then we also have amikacin, and one that you probably haven't seen used but historically was important is streptomycin. And there are a couple more, we'll leave it at that. You'll notice they all end in kind of icin or acin. So how is it that these antibiotics work? Well, let's look at our model bacterium here. And they interfere with one of these processes, and namely they interfere with ribosomes, so they interfere with creating proteins, and they actually specifically focus on the 30S subunits, which are drawn there. Now, something interesting to note is that while most antibiotics that prevent bacteria from making protein are bacteriostatic, which means they just prevent bacteria from replicating, they don't kill them, aminoglycosides actually are bactericidal. So they actually do kill the bacteria that they come into contact with. So what are these drugs used for? Well, one major use is they're used for serious gram-negative infections. I'm going to write GN for gram-negative. And why are we saying serious? Well, we're saying that because these drugs have pretty bad side effects. We'll talk about them. So you're not going to want to use them for a simple infection that doesn't need it. And often when you use them for these gram-negative infections, you're going to give them, in fact almost always, you're going to give them in combination with other antibiotics. Now they're actually also used for gram-positive infections, but in those cases they're given as what we call synergy or for synergy. So they're always given with another drug there, and they're given at a slightly lower dose, and the idea is that they help the other drug kill the bacteria. So an example of that is you might see gentamicin given with ampicillin. And finally, a third use is that these antibiotics can actually be used against mycobacteria. Now, what are mycobacteria? Well, that includes TB, it includes MAC. And in fact, streptomycin, the one we wrote here, was one of the first drugs used to treat TB. And we actually stopped using it for a number of reasons. Its side effects and also the fact that it has to be injected, but it is effective against TB. And you may still sometimes see it used for resistant TB when other drugs won't cut it. Now with that, I want to tell you 3 high-yield facts to remember about aminoglycosides. And the first is that they have no effect against anaerobic bacteria. And specifically I mean strict anaerobes, bacteria that do not grow in the presence of oxygen. Now the reason is that the way that aminoglycosides get into the cell is through what we call an oxygen-dependent process. So they won't be able to get in as easily for anaerobes. So do aminoglycosides work for Pseudomonas? They do, because Pseudomonas is aerobic. Do they work for Bacteroides? They won't have any effect because Bacteroides is anaerobic. Now the next thing to remember is that aminoglycosides are not absorbed from the gut. So what that means is if you want to treat some kind of systemic infection like you normally do, you can't give this drug PO, you have to give it IV. Now you might give it topically if you want to treat something very localized, or you could even give it PO if you want to specifically kill bacteria in the gut. But for any kind of systemic infection, you have to give it intravenously or intramuscularly. Now the third thing about aminoglycosides is, of course, the adverse effects. Can you think of the most important adverse effect that comes with aminoglycosides? So without question, the most important one is nephrotoxicity. Now a full 10 to 20% of patients getting aminoglycosides will have nephrotoxicity, which we define by a bump in creatinine of 0.5 or 50%. So this is really common and something to watch out for. Now the second most important adverse effect is, wait, what? I can't hear you. It's ototoxicity. So aminoglycosides can actually cause both cochlear and vestibular toxicity, which means theoretically they could give you permanent hearing loss or permanent disequilibrium. Now imagine having vertigo for the rest of your life. So that about does it for the basics, and now let's get on to dosing aminoglycosides. Okay, so dosing aminoglycosides is actually pretty complex, and we're going to have to go back to some pharmacology to understand it. The first thing to know is that aminoglycosides are concentration-dependent antibiotics. Concentration-dependent. Now, you may not know what that is, so let's go into it right now and figure that out. So to do that, we're going to draw a plot of the concentration of a drug over time. So here on the y-axis is concentration, and on the x-axis is time. And let's look at what happens after you give one IV dose of a drug. So as you give the IV dose, the concentration in the blood spikes. And then assuming that this drug is cleared by first order metabolism, we're then going to have the concentration of the drug fall exponentially over time. Now back in pharmacology, we learned about this concept called minimum inhibitory concentration. And that was the concentration beyond which bacteria would not grow in a culture broth if left for 24 hours. So let's say that right here is the minimum inhibitory concentration for this antibiotic. Now what concentration dependent means is that if we want to predict how well this antibiotic will kill some bacteria, what we mostly care about is the peak concentration of the antibiotic in the blood. So we usually look at the ratio of the peak concentration to the MIC, and that'll give us an idea of how well it'll kill some bacteria. Now the alternative to concentration dependent is something called time dependent. And for time dependent antibiotics, what we care about is not the peak level, but rather we care how much time did the concentration spend over the MIC. And in this case, that's denoted by this time segment here. And an example of a time-dependent antibiotic would be a beta-lactam like penicillin. Now, while we have this chart here, we can also mention that aminoglycosides have a post-antibiotic effect. And what that means is that the drug continues to work even after its concentrations in the blood have dropped. And so aminoglycosides, for example, once their concentrations have dropped below the MIC, like over here, they can continue to kill bacteria. So the question is, why do we care that aminoglycosides are concentration dependent? And the answer is that it explains why there's two ways to dose them. And let's talk about those two ways, and then we'll discuss why the concentration dependence is important. So the first way to dose them is conventional dosing. And let's look at a plot of the concentration over time with conventional dosing. So here again on the y-axis, concentration. On the x-axis we'll have time. And let's label our MIC so we have it here. Okay, so with conventional dosing, what you do is you give a loading dose, and after that the concentration drops exponentially as usual. And then every 8 hours you are going to give a maintenance dose. It's not necessarily always every 8 hours, but that's a reasonable number to use for now. So this would be at the 8-hour mark, this would be at the 16-hour mark, this would be at the 24-hour mark, and so on. Now the alternative to conventional dosing is extended interval dosing. And for that also, let's look at a plot of concentration over time. And here, as usual, is the MIC. Now with extended interval dosing, what you're going to do is give a much bigger initial dose. So it's going to climb up to a much higher peak. And then you're going to wait actually about 24 hours before you give the next dose. And by then, the concentration will really have dropped back down to 0. At that point, you give the same dose again, also a big one, so it spikes back up. And then you wait again another 24 hours, and by which time the concentration has really come back down to 0. So this is about 24 hours here. Now what you'll notice is that with this extended interval dosing, which was basically developed after conventional dosing was developed, the peaks are much higher, right? The peaks are higher than here. And so because aminoglycosides are a concentration-dependent antibiotic, that means that this extended interval dosing will be as good as the conventional dosing. In fact, you might even think it would be better. But if these drugs were time-dependent antibiotics, then let's look at how much time they spend over the MIC. This one is spending a couple hours here, but then you have all this time here where it's not over the MIC. Whereas over here with the conventional dosing, you see that you're spending more time over the MIC. So if aminoglycosides were a time-dependent antibiotic, extended interval dosing would not be as good as conventional dosing, but because they're concentration dependent, it is as good. So both are effective for killing bacteria. Now why might you want to use one over the other? Well, the theory is that extended interval dosing has fewer adverse effects than conventional dosing. And it's thought to maybe be because you kind of give your body this mini drug holiday right here. So in that case, you might think we should always give extended interval dosing. And that's not quite true because there are exclusion criteria. And some of those include having really poor kidney function, GFR below 30, or if you're old, or if you're pregnant, or if you have endocarditis, or a severe liver disease. So there's a whole list of exclusion criteria when you can't use extended interval dosing, but otherwise you should. Okay, so that's pretty much the conceptual part of this video. That's all the pharmacokinetics we're going to do, really. And so now let's get into the nitty-gritty of, if you were on the wards, how exactly are you going to dose this drug? What amount are you going to give? The first thing you're going to do to figure out exactly how to dose this is you're going to find out the creatinine clearance. And there's kind of two reasons for this. The first is, as we said, aminoglycosides are nephrotoxic. So if someone has bad kidneys, you would want to figure that out, and you may not want to give them aminoglycosides because they have limited renal reserve. But if you do want to give them aminoglycosides anyway, you still need to know the creatinine clearance because the way that your body gets rid of aminoglycosides is to clear them renally. It doesn't metabolize them, it just excretes them in the urine. So you need the creatinine clearance, and the specific formula that we're going to use to calculate that is called the Cockcroft-Gault. I hope I'm pronouncing that right. Cockcroft-Gault, that's one of the equations. And so the way you're really going to do this is you're going to go to Google. You'll look up a Cockcroft-Gault calculator like this one, and you'll put in your creatinine, your weight, your gender, your age, and it'll tell you the creatinine clearance. Once you have that, you're going to want to calculate dosing weight. Now, dosing weight is actually kind of complicated to calculate. Now, calculating dosing weight is actually kind of complicated. There's a couple of steps. The first step is going to be to calculate ideal body weight. And for men, that's going to be equal to 50 plus 2.3 times your height minus 60 inches. So of course you want to put the height in inches here, and then this is going to give you the ideal body weight in kilograms. This is all going to be in kilograms. Now if you want to find it for women, it's going to be 45 instead of 50, and otherwise it's all going to be the same. So this is for men, and this is for women. Okay, so now you know their ideal body weight. Now what? Well, now it kind of depends on how much they actually weigh. So if their weight is less than ideal body weight, then for the dosing weight, you're going to use their actual weight. Okay, so if they weigh less than their ideal body weight, you use their actual weight for dosing weight. What if they weigh a little more than their ideal body weight? So let's say they weigh between their ideal body weight and 1.25 times their ideal body weight. Well, in that case, their dosing weight is going to be equal to their ideal body weight. So if they weigh a little more than the ideal body weight, their dosing weight is their ideal body weight. Finally, if they weigh more than 1.25 times their ideal body weight, then you're going to use an adjusted weight for their dosing weight. And what it's going to be is their ideal body weight plus 0.4 times the difference between their weight and their ideal body weight. So it's kind of complicated, but this is how it's done. And so now we have both the creatinine clearance and a dosing weight, so we're ready to figure out exactly how much aminoglycoside to give. So at this point, we need to go to an aminoglycoside dosing chart. And I have one here, and we'll link to one below in the video details. So let's copy paste the part about conventional dosing into our canvas here. So this will tell us how to dose gentamicin, tobramycin, and amikacin. And let me just point out right off the bat that tobramycin and gentamicin basically have exactly the same dosing. You can see all these numbers are the same across. And so let's see how we would do this. So we know the dosing weight, and that's going to help us determine the loading dose. So let's say we're giving gentamicin, we're going to take 2.3 and multiply it by the dosing weight, and that'll give us the loading dose. Then to find the maintenance dose, we're just going to multiply the dosing weight by 1.5 to 2. And we're going to give that every 8 hours. But what if you have an abnormal creatinine clearance? How does that come into it? Well, in that case, you're not going to give it every 8 hours. You're going to give it perhaps every 12 hours if the creatinine clearance is 50 to 80, or every 24 hours if it's 30 to 50, and so on. Now you can notice that if you're treating a gram-positive infection, you're using gentamicin for synergy, there's going to be no loading dose. And likewise if you're treating a UTI. Now for amikacin, the numbers are a little different, but the procedure is exactly the same. Now the only other thing to know, in addition to these numbers, is that we need to check peaks and troughs. Now peaks we're going to want to check especially when it's a serious infection. We want to make sure our concentration is getting high enough to kill the bacteria. Because remember that aminoglycosides are a concentration-dependent drug. And the troughs we're going to want to measure to make sure we avoid toxicity. And we're going to check that perhaps before the 4th or 5th dose. And what should the peaks and troughs be? Well, for that we're going to return to our aminoglycoside dosing chart, and you'll see down here, if you go to serum concentration monitoring, it'll tell us what the peaks and troughs should be for gentamicin, tobramycin, and amikacin. Okay, so that was for conventional dosing. Now what about extended interval dosing? Okay, so what about extended interval dosing? So for that we're going to have to go back to our chart here, and we can take the extended interval dosing chart and put it into our canvas here. We're going to have to cover up some of the text. Now recall that for extended interval dosing there's no such thing as a loading dose, so it's a little simpler. Here's what you're going to give. You're going to give 5 to 7 times the dosing weight, and notice that that's significantly higher than the loading dose in conventional dosing. You're going to give that, and how often are you going to give it? For that you go over to the right side here. If they have a good creatinine clearance over 50, you give it every 24 hours. If it's a little worse, you're going to give it every 36 hours. But if it's below 30, you cannot give extended interval dosing. Recall that we said that was one of the exclusion criteria. For amikacin, you're just going to give a different amount, otherwise it's the same. Now with extended interval dosing, unlike conventional dosing, we tend not to check peaks. You're not going to check the peak concentration. And the reason is that we know that it's going to be high enough. because this is a pretty big number, 5 to 7. Unlike with conventional dosing, where someone with a weird volume of distribution may have a peak that's too low, that's not going to happen with extended interval dosing. But we do definitely want to check trough to make sure that the concentration is dropping to basically 0 as we expect it to. So let me just show you that in the chart here. For serum concentration monitoring for extended interval dosing, it tells us that the desired concentrations are undetectable for all the aminoglycosides for troughs. And when you check troughs in extended interval dosing, you can check right before the second dose. You don't really have to wait a couple doses like with conventional dosing, the reason being that you don't build up to steady state with extended interval dosing. Recall that the concentration should go down to 0 after every dose, so every dose is going to bring you back up to a peak and then back down to 0, and there's no building up like there is with conventional dosing. Now there's one last subtlety to note to make sure we don't get confused. So with extended interval dosing, you give a dose usually every 24 hours. But with conventional dosing, you might sometimes also give a dose every 24 hours, namely if the creatinine clearance is impaired. So does that mean that conventional dosing with impaired creatinine is basically the same as extended interval dosing? Well, it's not. They're actually quite different, and let's quickly draw some concentration curves to figure out why. So first, let's look at a regular conventional dosing concentration curve. So your loading dose is going to bring you up, you come down, you're going to give additional doses maybe every 8 hours or so, and it'll look something like that. Now, if someone has impaired creatinine clearance, after you give that first dose, the concentration of aminoglycoside is not going to drop quite as fast. So you have to wait before you give your next dose. And the doses are going to be the same, but you're going to give them less frequently. So these are both conventional. This guy has good kidneys, and this guy has bad kidneys. Now let's compare that with extended interval dosing for someone with good kidneys. There you're going to give a big dose, so your concentration really spikes high, and then you have good kidneys, so your concentration is going to fall all the way back down to 0, and then after 24 hours you'll give the next dose again, and then the concentration is going to fall all the way back. And so you'll notice that these two, conventional dosing with bad kidneys and extended interval dosing with normal kidneys, are not the same at all, because extended interval you have high peaks and your concentration drops all the way back down to 0, whereas conventional dosing, your peaks are not as high, and your trough does not go all the way back down to 0. And that distinction is really the important one to distinguish extended interval and conventional, not simply how often you're giving the drug. Okay, so that is dosing aminoglycosides. And so what you should definitely remember, aminoglycosides are nephrotoxic and also ototoxic. They are concentration dependent, so we care about what the peak to MIC ratio is. There are two ways to dose them. There's conventional dosing and extended interval dosing. And the dosing depends on creatinine clearance and dosing weight.